what we'll try to do today. Thank you so much for joining us for the Road to Residency, hosted by Tour for Diversity in partnership with the Latino Medical Student Association and the Student National Medical Association. Today's webinar is focusing on general surgery and surgical specialties, and we're really happy to have surgeons joining us from both the Society of Black Academic Surgeons and the Latino Surgical Society, really looking to help connect with students that are applying this cycle and try to answer all the questions that you might have to help you find a successful match this application cycle. I want to take the opportunity to welcome our panelists, Dr. Natalia Correa, who is a surgical resident currently, and she's training in Florida. We'll give you a moment to share a little bit about yourself as well. Dr. Andre Campbell, who is joining us. He is a trauma surgeon, faculty at University of California, San Francisco. Dr. Campbell, thank you so much for joining us today. Dr. Rita Belizaire, and she is also a surgeon joining us. Dr. Belizaire, I'm going to ask you to share with us what institution you're in.
So I am part-time faculty at University of Texas at Houston, and I own my own private practice called Houston Community Surgical in Houston, Texas.
Wonderful. Welcome. Thank you for taking the time to join us. We know we really value actually folks like yourself who have a very different perspective that our students are not often exposed to. So we really appreciate you sharing that perspective. And Dr. Theodore, you're also joining us. If you can share with us where you're located.
Yes, I'm a trauma acute care surgeon out of Boston Medical Center.
Wonderful. Thank you so much for joining us. And behind the scenes, we have a volunteer student. Bilkis, tell us a little bit about yourself.
Hello, everyone. I'm the current SNMA Specialty Interest Group Vice Chair, and I'm very happy to be here with you all. I'm currently a pre-med applying to medical school right now, so learning ahead of time.
We are so thankful for you joining us to help with our behind the scenes management. So we really appreciate your time and volunteering to help us host this webinar. I'm going to do a little bit of housekeeping, and just for all of the participants, we do want you to use our chat function and our Q&A function, both of which should be enabled. And so submit any questions that you may have through the Q&A. We'll try to keep track of these and answer the questions live. And if you have any messages that you want to share with the panelists on the chat, please go ahead and do so as well. To start us off, I want to just provide a little bit of background in terms of each of the panelists, and so I'm gonna go ahead and mute myself, and I'll ask you to share two minutes, your background, your path to surgery, and why you love surgery.
Okay, I guess I can start. Hi, everybody. My name is Natalia Correa. I'm a PGY2 at the University of Miami Holy Cross Surgery Program in Fort Lauderdale and Miami, Florida. I went to medical school at Florida State University, where I also did my undergrad. Born and raised in Miami. My parents are Colombian. I kind of chose to pursue general surgery because I wasn't dead set on a specific specialty at that point. But basically through rotating in general surgery, I realized there were so many parts of the body that you can operate on. I really loved the opportunity of choosing when to operate, when not to operate, and which kind of surgery would be best tailored for each individual patient and the, comorbidities or anything, pathologies that they brought with them. So I really enjoyed that process. And then just rotating through surgery, I realized that there was a huge deficit of Latina women, especially in academic surgery. So I kind of felt compelled and passionate about fulfilling that deficit. And that's how I ended up in general surgery. So very nice to meet everybody.
Thank you so much for sharing, Dr. Correa, and congratulations on moving up in the world of surgery. So now we'll go ahead and move on to Dr. Belizaire, and same thing, if you could share a little bit about yourself with us.
Sure. Well, thank you. Thank you for having me. So my name is Rita Belizaire. I am a general and colorectal surgeon. I grew up in Midland, Texas. My father is a retired surgeon, was born and raised in Haiti. I know we have a big Caribbean showing here on the panel. I ended up choosing to become a surgeon largely because he was a big influence in my life. I remember shadowing him, and I just thought it was really cool. Really, it was he would ask for something and somebody gave it to him. I mean, truthfully, that was like one of the things I was like, oh, that's pretty cool. But as I went through medical school, I really kind of liked every specialty. But as I went through surgical residency, I realized I really loved operating. I like taking care of sick patients. I like seeing them get better. There's the immediacy of treatment in certain patients. And so I really enjoyed that. And the reason I chose colorectal surgery is because I took a year out to do emergency general surgery in the South Bronx. And I realized that if I wanted to be either in a big city or in an academic center, I really didn't want, certain types of cases to be taken away from me. And one of the things I enjoyed doing was colorectal resections for cancer. And so I chose to do a colorectal fellowship, but have maintained both general surgery and colorectal surgery as part of my practice. And after a couple of years in Brooklyn, I ended up back in Texas because I had my daughter. I wanted to get closer to home. So I was at UT Houston full-time for about 4 years. And then just over a year ago, I opened my own practice in Houston and have maintained that relationship with UT. So I still work with medical students and residents part-time at our county hospital as well. So thank you for having me on the panel. Looking forward to our discussion.
Thank you so much for sharing that. And I'm gonna follow up in a minute after we introduce everyone. We'd love to hear a little bit more about what it was like to have that inspiration from within your own family. We don't often see those stories of multiple generations. Dr. Theodore, if you don't mind going ahead, and we'll ask for your story in medicine and surgery.
Yes. So my name is Dr. Shayna Theodore. I also have that Caribbean background. Both of my parents were born and raised in Haiti. I am first generation here in the States. Grew up in Brooklyn, a New Yorker through and through. Went to Pennsylvania for med school and then have stayed in Massachusetts since residency, fellowship, and now at my attending job. Originally, I just went into medicine because I wanted to be a pediatrician. That was the only doctor I saw and knew in my community because I went to my pediatrician and they made me feel better. But going through the path, I did a Bachelor of Science MD program out of the City University of New York called the Sophie Davis School of Biomedical Education. And it exposed me to many of the specialties in medicine very early on. And although shout out to all the pediatricians, a very, very noble specialty in medicine, for me, I felt more so that I needed to be more hands-on and wanted to see sort of the same things, that immediacy of you're not doing well, I can evaluate you, I do something and you feel better. So that really drew me towards the specialty in surgery. And then taking it further, trauma and ICU, I wanted to not sort of pine cone myself into one space in the body. So being a trauma or an acute care surgeon, being able to do trauma surgery, general surgery, and ICU, I'm able to operate in the neck, in the chest, in the belly, and sometimes in the most extreme moments in people's lives, and not only impact them in a physical way, but thinking about them from the social aspect and how we can approach them from a trauma-informed care lens and see what sort of social support services we can offer them and their family. So having that well-rounded experience really makes every day of my job feel like it's not work.
Wonderful. Welcome. And thank you again for joining us. And we'll be piggybacking a little bit off of that. Dr. Campbell, if you wouldn't mind sharing with us a little bit about your story as well.
Well, good evening, everyone. It's really great to be here. I want to thank Dr. Romero once again for having me to come and speak to this really important session, talking about the road to residency and what it's like to go into medicine. And I'll just share with you a few minutes of what what brought me to surgery where I'm at. I've been doing it now for a long time. But when I started out, I kind of didn't really know what I wanted to do. I mean, I went to college from New York. We have a big, talk about acute care lens. We got a big New York lens today, which is fantastic. I'm born and raised in New York City. I went to college at Harvard. Then I did some work for a little while. And then I went to medical school at the University of California, San Francisco. Then I was not sure what I wanted to be when I grew up. I didn't have any doctors in my family. I'm first generation. My family is also have a big influence of Caribbean here. My family's Jamaican, and I was born in the United States. So, we have a lot of common interest here, between the different islands in the Caribbean, which is fantastic. So, when I was in medical school, I was heavily influenced. I was trying to figure out where I wanted to go, whether I wanted to be a medicine doctor, a surgery doctor. In fact, at one point I was thinking about being a pediatrician and obstetrician. So I was kind of all over the map a little bit when I first started out. And then, so what I did is I applied into residency, and I actually did something that was probably not a good idea. I applied both in medicine and surgery. And then I decided I would do medicine because it was sort of the path. One of my attendings had said it's the path of least resistance. And if you're not sure, it's a way to start out. So 1 year turned into 2 years, turned into 3 years. I did my whole residency in internal medicine. So I'm a fully certified, at one point, a primary care doctor and a fellow at the College of Physicians. Then I switched into surgery because I wanted to do a little bit more for people. The thing that I found was a medicine doctor, although medicine is absolutely fantastic, especially for me, I wanted to be able to make a difference in people's lives. I was trying to figure out, okay, should I go to cardiology, pulmonology, or another pulmonology, cardiology, or GI. And I said, no, I'm not going to do that. I'm going to be an interventionist. I'm going to be a surgeon. So I switched into surgery. I went through the match again, and I ended up training my whole time in the East Coast at Columbia, New York Presbyterian at the time, or Columbia University Medical Center, Uptown. So I spent 8 years there doing my training in both medicine and surgery and surgical critical care. So as I finished, I was really focused on taking care of injured patients and doing ICU care. And I ended up getting a job at the University of California, San Francisco, where I'm at now. And I've been here now for a long time in doing that. So I get a chance to do a lot of different things. I do general surgery, I do ICU care, and I ran an ICU for 20 years. Also, surgical educator, I ran the clerkship for 20 years. I ran a lot of different things. Now I'm the vice chair of diversity, equity, inclusion at the University of California, San Francisco. So really focused on diversity and developing diversity at our university, which we've not been so good at doing for a long period of time. So that's kind of how I ended up doing that. So I do general surgery. I love riding on my horse and saving the day, which is fantastic. I get excited when I have a difficult problem that I'm trying to figure out, trying to take care of someone. And, I'm like, yeah, I'm here to save you. And that's what I'm going to do. Right. So, but now the hard part about what I do, because I've been doing this for a long time, is that pretty much I can tell if somebody's going to make it or not from the beginning. But sometimes I surprise myself and things come through. So I'm always excited to go to work. Every day I learn something different, and I get to kind of get in there and do what I have to do to save somebody's life. And that's absolutely fantastic. It's a tremendous privilege to be able to do what I do and to be able to save people when I can. Also, I do general surgery, elective surgery. So I do elective surgery, I do emergency general surgery, I do ICU care, and I do ward work. So I do a lot of different things. I do outpatient clinic too. So I do a lot of different things, and everything's equally exciting to me. The acute care surgery, ICU, and trauma, it's all fantastic, and I really enjoy it. So with that, I'll just turn it over to Minerva again, and we'll see what questions you guys have for us tonight. And
Absolutely. Thank you so much, and welcome again. I want to, I'm going to ask the participants to check. We should have the Q&A function enabled. So if we can go ahead and test that, you can submit your questions. I'm going to ask everyone, all our panelists, to share a little bit about what do you think, I know I'm involved in reviewing applications and mentoring students. Our students are always worried about how can they be the best applicant? How can they be the most competitive? If you can think of 3 qualities that you look for outside of research, good grades, and certainly the basic application materials, right? So what are you looking for outside of meeting the minimum? What are 3 things that you look for? Dr. Belizaire, Dr.
Yeah.
Theodore, and then we'll go with Dr. Campbell last.
Okay, so a couple of things that I really like to see on applications are people that have had experiences where they have to interact with other people, whether that's having worked previously, whether that's team sports, also having done that at a higher level. So, not everybody has done this, but I know that people who have played sports at a high level, particularly team sports at a high level, know how to work with a team during stressful, difficult situations. So I like to see evidence that you have had to participate in activities where you are working in a team or working with other people. The other thing that I also like to see, and this sometimes doesn't come out on the application, but often will come out, unless it's in the personal statement, but often will come out in the interview, is, life experiences that make you able to relate to patients. I think, all of the applicants that we get by the time we're interviewing them are very book smart. So I'm not personally that worried about, you being able to like read a book or learn a concept, but are you able to relate to patients? Are you able to interact with nursing staff? Are you able to interact with, surgical techs and patient family members? So I want to see something where you have shown me that you are able to interact with other people, particularly during stressful situations. I think, like I said, having played team sports, having worked jobs, overcoming adversity, those sorts of things tell me a little bit more about your character, which is, one of the things I like to see in addition to just, grades, board scores, those sorts of things.
My turn.
Well, I guess you want me to go next? Okay, so well, I agree with what she has just said about all those things I'm looking for. I was just reflecting, I guess each year over the last number of years, I'd say if I write anywhere between 10 and 15 letters recommendations for our students a year. So over a 30-year period, I've probably gotten about around. I really like talking to folks. I mean, I also for 25 years, I run a fellowship, and this year I ran through 140 applications, interviewed 40 people. Same thing for the residency. We'll have about 800 or 900 applications. I'll be responsible for looking at 300 or 400 of them. So I have just a few minutes really to get a glimpse into I'm always looking at a personal statement to see what you have to see, because it's really sort of fascinating. So when I did mine, I did it 10 or 15 times. Some people just get disgusted and do it once. I would say, you really need to work on that, because it's a lens into kind of who you are, where you're at, and what you're doing. I mean, all the things we're looking at now, a lot of places have gone to, and even UCSF, we've gone to eliminating grades and also AOA, because there were a lot of bias in the grades that we had. Even though I was able to kind of turn it around when I was the clerkship director, they decided they wouldn't do it. So now we have to look at these other things that you have, what kind of outside activities you have. Or I am always humbled every year, every time I look at applications, because I don't even know how I got into surgery. And when I look at the immense talent that you guys have, it's just mind-blowing. The companies you found, where you travel, the things that you've done, you work through, adversity, with all the things happening with your family. So I really admire all the wonderful things that you do. And I'm always excited, because it makes me feel great that the next generation is going to be just absolutely superb. And it's what you're doing is truly remarkable. And your chance in the application is really to shine, to really give us a good sense of who you are, where you came from, distance travel, all those things I'm looking at, because that's really, for me, the exciting thing, just kind of seeing where you are and welcome you really into the world of surgery, because to me, surgery is the best specialty. It's really the way to go. I mean, and I'm out here trying to save souls every day, right? To try to get as many people to go into surgery. So that's what I'm trying to tell you, that I'm trying to brainwash you, trying to tell you to come my way, because you're going to have an absolutely fantastic career taking care of people and making a difference in people's lives. And that's really what you have to do. So those are some of the things, and those things that resonate with me as I sort of think about the question that you have. Thank you.
Yeah, absolutely. Thank you. And Dr. Theodore.
Yes, so one of the main things I look at in the application are things that are going to translate into you being a great resident. So consistency is a really big thing for me. When I'm looking at your CV, I'm not so much looking at the number of publications you have or the number of awards or all that. That's all great. And you should be very proud of yourself for achieving those things. But what have you been consistent in? Like, what have you seen through from start to finish and have shown like your passions in what you're doing? Similarly, what stuff have you been able to show how you're a team player, or how you've overcome adversities, or how you work in high stakes situations? All of those things are going to be situations that you're going to be facing while you're a resident. And I want to see how can you do with that. Programs really look for, there's a lot of smart medical students out there, right? Really look for how well are you going to fit in their program. It's like a surgical Tinder almost, right? Like, how is it going to be, is it a good match for what you're looking for and what they're looking for? So the biggest advice that I give my medical students, I'm the associate clerkship director for the third year surgery rotation here at Boston Medical Center, is I tell them, be your absolute complete self. Because although you might be looking around and saying, oh, I need to be on 20 projects, or I need to be on, research is important, I get it. And if you're passionate about it, don't let me deter you. But if you used to work at an animal shelter since you were 12 years old, and you do that every summer, and you started a program that helped to get, foster pets into home, that shows a lot of determination, perseverance, a lot of teamwork. And those are characteristics that you might feel like, oh, I was just doing this thing that I love, but actually you're showing us how great of a resident you will become.
Thank you so much for that perspective. And I'm gonna go last as one of the faculty members who also reviews applications. I tend to look for, similarly, we all want to get applicants who are highly accomplished academically. But most of the time, by the time you get to interview, you've already made it through that. So, things that I look for are things that sometimes we can't really teach in residency. That would be things like your work ethic, things like the altruism that you bring to the table. And as some of the other speakers, that really has to do with having compassion and in the care that you provide to patients. And really looking for sort of that go-getter attitude, because surgery is tough. Surgery residency is grueling, and it really does speak to, what we traditionally think of as the surgical personality. So I do look for people who seem to have that kind of initiative, just because that's not going to necessarily be something that we can teach you, especially when you're exhausted and you haven't eaten and you might be a little bit sleepy. And so, we really want to find people that are going to bring that element to the table already. The last thing that I want to touch on, and there's a couple of questions that have come up about this in terms of how many research publications we have and how many make a candidate really competitive. One of the things that I would consider is that you may not need to emphasize research publications as part of your application as much. If you're applying more to community programs, it will definitely be something more critical to programs that are academic, and particularly if you're applying to or really looking to match at programs that require research time. When it's not something that's required, the community programs tend not to actually emphasize that, because a lot of times that's not a major requirement to complete your training. And also the infrastructure may not be present at community programs to really support someone who's really interested in doing a lot of research. And so in those programs, sometimes that high research publications and having someone who's really looking to be involved in research may not always feel like a good match, simply because the program may not be able to meet your professional needs. I'm gonna ask for the other panelists to weigh in terms of the research publications. How much do you think applicants should focus on a specific number of publications?
So-
Oh,
Go ahead.
you didn't get to talk yet.
No worries. I was gonna say, being that I went through the process a little bit less than 2 years ago, I would say I would agree with Dr. Romero's sentiments in terms of community. The places I interviewed at that were more community-based, they focused less on research rather than the larger academic institutions that had that infrastructure to support research, especially the ones that required you to take 2 or 1 year off to do research. That being said, I think if you're going to have research on your application, it should be something that you can speak to very well, because they're going to ask you about it. So it's not really so, again, like the quantity rather than, the quality of the research and showing that you actually had a lot of input in those projects. They're going to ask you about that. So that's what I would say. That being said, there are programs that probably put a filter in terms of how many, research publication items you have on your application, but I don't think it's the bulk of them. I think a lot of it comes down to how well you can speak to the current projects you have, but I don't think research will ever hurt you. I think it can only help you in an application.
So if I could just go for a minute, then I just say about a couple of things. The first thing is that each program is a little bit different. All right, so you're basically, if you're applying to a place like our place, for example, I work at the University of California, San Francisco, or places like Hopkins, Boston University, all these places like that, they're going to be a big focus on the number of publications you have, because that's sort of the currency that now used to be you can do things, but maybe you didn't get a publication. When I came along, I didn't have any publications, right? But now it's a little bit different in the environment, because it's sort of some of the currency that we do it for the high-powered academic programs. Now, remember, there are different layers that we have now. You can get excellent training in all kinds of different programs. There's academically based programs we require to do 2 years. And there's also university affiliated community programs, and there's community programs also. And they're freestanding academic programs. So there's a lot of different types of surgery residency programs, and each one emphasizes a little different. If you're applying to a community program, it's not so important for you to have this currency that we deal with in academics, whereas in academic programs, we do look at the number of publications, what you've had, what you brought to fruition, those kind of things there. So it really depends on what your focus is. You can get training in many different areas. It really depends. If you want to be an academic surgeon, then you would go to an academic program when you're applying, but it really depends on your goals. Each of us have different goals of what we want to do ultimately, and you got to make sure that you're considering that as you lay out your application, because that's sort of something that academic programs will look at when you're applying. So that's just a few thoughts about the research papers presentation, because it's really creative work. It's posters, it's abstracts, it's presentations, it's papers. That is a currency of academics. So those are the things that you can be involved with. And you always look to make sure that you're trying to do something that's creative, because it's really that's creative exercise that you're doing. But there are other things you can do also that make your application strong. And there are times that we get an application that may not have many publications, but they've done so many other things that sort of makes their application so strong, which kind of makes us all kind of excited about training the person, because I'm always looking for someone who's fun to train, someone who has fire in the belly, and the fire in the belly is not this Pepsi that you get when you eat the wrong things. It's the things that you're excited like when somebody lights up, like I'm doing something, you're doing something really fun, and I'm like, wow, that's fantastic. That's the kind of things I'm looking at with that. So that's just a few thoughts from my end of the, thank you.
Thank you so much. I'm gonna let's move on from this research question, and there are a few questions in the chat. So I'm gonna ask Dr. Theodore if you can chime in on this. Denise Nemeth is asking, Eris allows 10 experiences with only 750 characters to describe. What kind of advice would you give on writing these descriptions so that they can be engaging and can capture the essence of each experience? Do you have any key words that can be used for the descriptors and making the most out of these? And I'm going to ask Dr. Theodore to answer in the live session, and the rest of the panelists will type out a short answer for this as well.
Okay. So thank goodness that they only allowed 10 experiences and 750 characters, because surgeons have short attention spans sometimes, and I don't know if we could read through more than the 10 experiences and 750 characters. But I think the things to focus on again is making sure the characteristics and the personality traits that you want to shine through, that you believe are going to translate into you being a great resident, come through. And then also taking the time. Oh, okay. Also taking the time to talk about something that's sort of fun, a little bit out there, maybe eccentric. For example, say you were a gymnast for X number of years, or say you worked in your family's restaurant, or something like that, where you feel like, well, what does that have to do with surgery? It's interesting, right? Want to work with people that are going to be good to work beside. You're going to be doing 24-hour calls. You're going to be in the trenches with these group of co-residents, with the fellows, with the faculty members. So try to stick to the characteristics that show that you're consistent, you're persistent, make sure that they show the things that make you a good resident, but also have a little bit of fun, get a little bit eccentric, tell a little bit of a story, talk about something that may not be related to surgery at all. That's fine. We would love to read that. Kind of breaks up the monotony of the applications.
Thank you so much. Dr. Belizaire, I'm going to ask you to answer this question that came from an anonymous attendee. And I'll ask for some leeway for everyone. Do you have any specific advice for reapplicants? I'm going to preface that by saying, can you give us advice for reapplicants who are in a preliminary program, and for reapplicants who perhaps didn't match and are doing a non-surgical year?
Yeah, so I think one of the things that I like to hear from people who may not have been successful in their first application is whether or not they sought feedback from either a mentor or, program director, other, residents, whomever, as to why they believe they didn't match. A lot of the times it can just be something easy, like not easy, but obvious, like board scores, those sorts of things. I think one of the things that we all do and we continue to do throughout our career is reevaluate things that we could have done better, right? During residency, M&M is, that's something that we do every single week to figure out what we could have done better. And that kind of starts with when we have our first, failure, or have our first experience where we didn't have the outcome that we wanted. So always looking back and, trying to objectively look at and see what is missing here. What did I do wrong? What can I do differently? And seeking, crowdsourcing advice from mentors or people who have been on, committees that, look at the applications. I think being insightful is the first step towards learning how to become a surgeon that is always trying to get better. So if I hear an applicant, for example, come on an interview and I say something like, why do you think that you weren't successful the first time around? And there's a lot of like, well, they did this and I did, and like, and there could be some, there could be some aspect of it where there was just injustice, but looking at what can I do differently will always be, you know, a component of your life as a surgeon. So if I hear that you looked into that and then you did something to change it, that tells me that you are insightful. You acknowledge that there are things that you can do better and that you actively try to change those things. I think that is that shows a certain kind of character of somebody that will be a good surgeon. Somebody that sits back and blames all other aspects of why they didn't match is a little bit of a red flag to me, because if you have a surgical complication, you're not looking inward at what I could have done differently. That's a little bit of a red flag to me. So that's what I would say. That's probably the biggest thing.
Thank you so much for sharing your perspective. I'm going to ask Dr. Correa to give us the perspective from the applicant's side in terms of the signaling process. That's a very new aspect of the surgery application, and I'd like to see if you can answer that specific question about the 15 signals that general surgery applicants can use in their match process.
Yes, so when I applied, I only had 5 signals. So that's very new in terms of increasing it to 15. I would say, so I got mixed advice in terms of the signals. A lot of people didn't understand how they were going to use the signals at the time. Some people liked the signals to kind of help them connect to programs if they perhaps weren't in that region. So for example, being on the East Coast, you know, if I wanted to go to a program on the West Coast, those were programs that I would utilize to signal as well, or programs that perhaps I didn't have any particular connection to, but I was very interested in those programs. I would recommend using signals for those programs. For myself in particular, knowing that I wanted to stay in Florida, and you know, this was kind of like the biased area that I was in, I didn't tend to use signals in this area or like my state, because I had so many things on my application that tied me to Florida, being from Florida. So I would say for the signals, either using it for programs that you think you might be on the cusp in terms of competitiveness, or perhaps getting out of the region. I think that would be most helpful in terms of utilizing those signals.
Awesome. Thank you so much for sharing that, Dr. Correa. I think that's a very new part of the process, and it's really great to hear what your experience was like. I'm going to ask Dr. Theodore to also weigh in on the faculty side. How have you guys found the signaling process to be of help?
I think if you're signaling, it helps to sort of understand that my perception is that you have looked into my program, you have saw what we can offer, and you have found specifics within it, be it geographic, be it preparedness for a fellowship you want in the future, be it a research lab, whatever it is that's particular about my program that you feel like resonates with you. And out of all the programs that you could have you chose to signal us. So that's how I'm hoping that it's being used, because that shows that you have the foresight and the intention to really do a deep dive, and then after doing that have super selected and chosen programs that really best fit you.
Thank you so much for sharing that perspective. I'm going to answer another question that came up live in the chat, and it's really regarding STEP scores. So Dr. Belizaire, if you can chime in on what is it that our participants can what takeaways can they have about STEP scores? Keeping in mind, step 1 is now pass-fail, and a lot of the attention has shifted to step 2 score.
Yeah, so this is somewhat new since I became part-time. I was much more active in the residency application process when I was full-time a little over a year ago. And I also sometimes might be the wrong person to answer this question, because as we all know, there is quite a bit of bias in standardized testing. And those of us who have worked in the DEI space know about stereotype threat and just not performing to our absolute best, even if we know the answer to a question. Sometimes, standardized tests do not show exactly what our fund of knowledge is. That said, it is a way to stratify people's fund of knowledge. So I would say that because it is an easy metric for programs to measure, most likely they're going to keep using that as a metric to measure. So now that step one is essentially out of the question, I think there's going to probably be much more emphasis on the step two score. At UT, what we used to use the step two score for essentially is if students, let's say they didn't meet whatever the threshold was for our step one score to get an interview, we would look at their step two score. And if the step two score was, way above and beyond, they would still go into the pool of people that could get an interview. So, as much as I wish all the standardized tests were pass fail, I think, sometimes even if we don't like something within a system, we still got to work within the system. So, you do your best to get all the resources that you can to study for it, make sure that, I believe in things like manifesting a good score, like having a good positive attitude, making sure you do all the things, sleep and have a good breakfast and all those things to ensure all the modifiable things that we can modify, do all those things to ensure that you still get as good of a good step two score as possible. Because if there is a way to filter that out, it's still going to be used as a metric for filtering applicants out.
Thank you so much. I think that's so key for all our participants to hear that. And it's really important to know about a well-rounded application. I'm going to move on to the next question, which is coming from anonymous attendee. And the question really speaks to talking about the challenging aspects of being an applicant and maybe deficits, right? So leaves of absence during medical school, step one failures. What impact does this have in an application? And so Dr. Belizaire touched a little bit on the step scores. We're going to address the leaves of absence and any failures. And what I'll say about this is that you do have to address it head on. Know that a lot of times having an exam failure is going to oftentimes be used as a screener, meaning you will frequently find that programs who heavily emphasize standardized exams will use that failure or that very low score to screen students out. And as much as we would like to say that there's no reason to do this, I can give you the example that at the programs where I have worked, there have been 3 to maybe 4 categorical surgical positions. And even for those smaller programs, we are reviewing 1,000 or more applications each year. And so we do have to use some metrics where everyone is trying to move away from that and using holistic review. But it is not uncommon that a failure will be something that unfortunately keeps you out. I would say have your mentors look at your personal statement and give you tips on how to best address the leave of absence or a step one failure. And what you really want to address is how were you able to turn this around into a positive, right? What did you learn from it? What kind of growth are you showing that is now going to make you not then also have that same problem in residency? Why do we emphasize standardized exams so much? Because you will continue to have standardized exams throughout your training. That includes every residency program, not just general surgery, but pediatrics, medicine, all of the programs have in-training exams. And so you will continue to need to do these. And when you become a surgeon, when you graduate the training program, you will then need to do a standardized exam to become board certified. And so those are really important aspects at this point for our careers. And actually, even after you become board certified, we are still taking exams for something called maintenance of certification. So it's kind of like a never ending hoop that we kind of have to jump through. Dr. Campbell, I'm going to ask if you don't mind also sharing your perspective on this particular piece.
Okay, so I have to say that I'm not a great test taker. So for those of you who are in that situation, welcome to the club. So you have to figure out a way that you can absolutely do things the best that you can, to figure out a system that you have to review things. I mean, I've taken so many tests now over the years. I've taken certification, recertification multiple times, you know, on multiple board exams, and you have to figure out what works for you with that. That being said, that is a screening tool. Step one has now become has gone away, so now it's step two. Now step one used to be a screening tool, and the USMLE said we didn't want you to do that. So now what happens? Step two now becomes a screening tool. So try to do as best you can. You know, work with as much review materials, figure out if you're oral learner, visual learner. All these, everybody has different learning styles. You have to figure out what works for you to sort of help you do as best as you possibly can, because the average score on step two is actually going up. The step two scores are now at 255. I agree with what was said on the leave of absence issue. It is interesting now, when I went through many moons ago, it was only people who had academic difficulties who had leave of absence. So if you had a problem, you take a year off to do that. But at our institution now, 45% of students are taking an extra year, and what they do is they find a research project. The university supports them because we tend to have a fair amount of research funds around at our institution, so that 40-45% actually will do that. So that's actually something that is a way that the students do to improve their application by getting involved with research projects, doing things that they excite them. Like, when people ask me, should I take a year off? I respond is like, okay, well, what really excites you? And then we kind of explore it and talk about it, and they look at different projects folks are doing, and then you kind of do that. So that is one reason. But whatever you do and whenever you take time off, you have to explain clearly why you took the time off. If there's an issue where you're having problems with exams, you have to face that head on, because there are programs, this is WMC data, but they will not interview you if you have failed the board examination. When there are places that will, some places that won't. You have to actually look at that. I can't remember the latest data on that, but this is something that does come to bear in your application, unfortunately, because I think that these tests are really overused, having spent many years taking them over, taking the tests, on different recertification now. So this maintenance certification is now changed, where every 3 years we have to take an exam, which is now it's open book, where it used to be a high stakes. You spend 3 months studying, you go and take a 5-hour test. All that stuff went away because they realized it was taking too much time away from surgeons, whether that's in private practice, academics, whatever you're doing. It's just taking too much time and effort to do that. So they made it a little bit more user-friendly for the recertification. The first certification process is serious in surgery. You take a written test, 6 hours, then you take an oral test, and you become certified. So qualification, and then there's a competency oral exam that goes along with it.
Thank you so much for sharing that. I'm going to ask Dr. Correa to chime in. There's a question about residents' socials and meet and greets the night before. What do you think makes applicants stand out?
So I would say it's more of an opportunity for you to get to know the program rather than those programs to get to know you. I think it helps you stand out to ask questions that aren't, already on the website, showing that you've already done substantial research about the program that you're interested in. So make sure you don't ask questions that are readily available, on their social media or on their website. That's your opportunity to get to know more personally about the experiences that the residents are going through. They will also typically at the end of these socials share their own social media or their emails to follow up. That would be more of an opportunity where you can, if you're particularly interested in a program, and the chief resident dropped their email and you want to ask them more questions, that's more of an opportunity to kind of establish that relationship with the chief resident, and that could help you perhaps in the future if you interview there. But, you know, they're seeing so many students, and if you're not memorable, it's not necessarily your fault. It's just kind of, this is an opportunity for them to just allow students to ask questions in a more informal setting.
Thank you so much for sharing that perspective. And I will tell you that I generally also look for, you know, how is this person going to sound at 2 a.m. and am I going to be able to listen to their consult during that time? So we're definitely, you're screening us for the crazy, we're screening you for the crazy. Dr. Belizaire, I have a question that I'd like to ask, if you can provide some advice. What advice would you give to our international medical graduates?
Oh, man. In terms of applying to surgical residency, I mean, this is the thing. This is a hard one. I would apply to obviously as many programs as you can, but I would, you know, you have a unique opportunity to talk about what your experience has been at your program and how that gives you an advantage in terms of how you treat patients. So, you know, for example, in a lot of other programs outside of this country, there's a lot of things that you have to do, for example, that maybe some of the programs don't have to do here. So you're already like drawing blood, or you're doing a lot more in the operating room, or, you know, the way you're interacting with patients. I think telling them what your experience has been at your program, which is unique and different than what is being done here, is very important. So that gives you a unique perspective on how to take care of patients. The other thing I find, you know, especially Houston, San Francisco, New York, like all of these, Miami, all of these places are very multicultural. So having that background and that experience only makes a program richer. If you can impart the experience that you've had internationally, where you are able to take care of a very diverse population, I think that is only an asset to a program. Now, depending on who the leadership is at that program, finding that to be an asset, I think it's important to know which programs tend to hire more international students. See what you can do about, you know, getting in touch with their residents, getting in touch with the program director, letting them know that, like Dr. Theodore, I think, said, you know, in finding out about their program, knowing that they have a large international student population is important. So it's very hard because the bias is there. The bias is definitely there. And you may not be starting from a starting line behind, but there are a lot more hurdles to jump through. So I think just demonstrating your value and how it has been enriching for you to train somewhere outside of the United States, and showing the experiences you had will be very important.
Thank you so much for sharing that perspective. I know that we're coming up on the hour that this webinar was scheduled, so I do want to take the opportunity to thank all the panelists. Again, Drs. Belizaire, Dr. Campbell, Dr. Theodore, Dr. Correa, who have taken their an hour of their time to join us and to really share all of these great pieces of advice for everyone. I want to encourage anyone who still wants to stay and get answers to some of the questions that we haven't gotten through. I'm going to make a commitment to go ahead and stay and at least try to answer some of these questions. Bilkis, if you are able to stay on with us, we appreciate your time as well. And I want to just acknowledge everyone who has participated before we wrap up. There is a question in the chat still that says, I've been advised by my mentors not to mention a fellowship that I'm interested in. And some programs have a very heavy transplant program. it's also consistent through my application. Do you agree that it might give the impression that I'm too focused on transplant and that being tailored to the program? And so I think this is a great question. I do frequently joke with applicants that we're going to review your personal statement when it comes to graduation, and that if you didn't apply to fellowship and what you said you were going to do, we're not going to let you graduate. But you know, in reality, of course not. It doesn't become a binding document. I think the important part of someone who has strong interest is it's great to find programs that match that and that will help you meet those professional goals. That's a really key point, as you have heard from all of the other speakers throughout the questions that we've been answering. But also be flexible enough and have that sort of open-mindedness that you're still training in general surgery. And so I'm an endocrine surgeon. I think it's great that you want to apply to transplant fellowship, but when you're taking care of my patients who just had a thyroidectomy or a parathyroidectomy and they're experiencing hypocalcemia, I want to know that you're still interested enough in doing a good job and learning from my cases and learning about the care of my patients, because you're still going to be expected, again, to be able to say you're a fully trained general surgeon and that it's going to be a pleasure to work with you and that you're not going to be disinterested or disengaged. I really do think that that's ultimately the key. Dr. Theodore, what are your thoughts on that specific aspect of the application?
So I 100% agree. I think that there are two separate attitudes that sort of shine through when medical students and residents declare their fellowships fairly early on. One is that they are only in the residency to get the experiences that will help them to excel in that fellowship, which I think puts them at a great disadvantage. And two is they want to get as much experience from the general surgery residency so that when they do go on to that fellowship, they can, even though it may not be that they're still taking care of those different aspects of that patient's care, but they understand that that information is valuable. And at least, you know, if they need to call a consultant for something, they're able to call it in an expert type way. And I think if you are of the latter of the two, then that's phenomenal. And there's nothing wrong with knowing what you want very early on. Just understand you got to get the experience for everything because you have to soak up residency. You really do, because it's a time of exponential learning.
Thank you so much for that. There is one more question, and that question is from Neosha, who asked, there is a standardized letter of evaluation for surgery. Is there any advice that we can give about the standardized letter of evaluation? And I'll open this up for anyone to chime in on this.
Yeah, I was involved with some of that at the Board of Governors, American College of Surgeons, and it was a way to kind of standardize things. But I like, even though I write a lot of letters, I like trying to make it very personalized. I meet with the students. Once in medicine and once in surgery. So I know what it's like. It's very stressful, and some days you're great, some days you're not so great, and you have to make sure that your mentors, whoever they are, kind of help guide you through the process so that you could be successful. Because that's really what they're trying to do, is make sure that you're successful in a process that you're applying through surgery. So that's sort of something that's very important, I think.
Thank you so much. I appreciate so much your perspective on that. I do want to encourage all of our participants to become familiar with the individual program items that they're asking you for. And also, you know, keep in mind that every program has its own website that you can request information for, and you want to be familiar with that for each of the programs that you're applying to. I want to take the time again to thank everyone. I know that Dr. Correa was starting her shift, and so I do appreciate her time. Unfortunately, she had to log off. But again, I want to thank all of the panelists, the organizations that have helped to support this. I myself am very happy to be a part of the Tour for Diversity mentors. I've been a part of Tour for Diversity for over 10 years, and it's really an important part and something that I value. And this is the 5th year that we've done the Road to Residency series. So we're really excited and really thankful that this has become a space where we can really take action to help all of you become better prepared for the application cycle. With that in mind, I am going to make a close for the webinar, and I'm going to also type in the chat a video that it comes from the NRMP, and it does explain what the match process is like. I'm going to play that video as well, just to close out the webinar, but I'm typing the link in our chat so that you can see it. And with that, I'm going to say good night. I'm going to close out the webinar right after the video. And thank you so much to everyone for joining us.
The NRMP uses a computerized mathematical algorithm to place applicants into residency and fellowship positions. At NRMP, we call it the matching algorithm, as we use it to match applicants to their most preferred programs. The algorithm is applicant proposing, meaning it initiates placement of an applicant into a program based on the choices made on the applicant's rank order list and not a program's rank order list. However, for a match to occur, both the applicant and program must rank each other. Once started, the algorithm attempts to match each applicant to the applicant's first choice. If that can't be guaranteed, the algorithm will try to match the applicant to the second choice, and so on, until the applicant is matched or all choices have been exhausted. Let's run a match to see how it works. 5 applicants, Arthur, Sonny, Joseph, Latha, and Darius, and 3 programs, Mercy, City, and General, have submitted rank order lists. Each program has 2 openings. Starting with Arthur, we see he ranked only City. Because the algorithm is applicant proposing, it will attempt to match Arthur to City. City has ranked Arthur second, and because there are no other tentative matches for City, Arthur is tentatively matched to City. Matches are considered tentative because an applicant who is matched to a program at one point in the matching process may be removed from the program later to make space for an applicant ranked higher by the program. Sunny also ranks City first, and the algorithm attempts to match her there. City ranked Sunny third. Because City has 1 opening left, Sunny is tentatively matched to City. Joseph also ranks City first. The algorithm attempts to match Joseph to City, but because both openings are tentatively matched to higher ranked applicants, Joseph can't match at City. The algorithm now attempts to match Joseph to his second ranked program, General. General has ranked Joseph third. Since there are no tentative matches for General yet, Joseph is tentatively matched to General. Latha ranked Mercy first, but Mercy didn't rank Latha, so she can't match there. The algorithm moves to her second rank, City. City has ranked Latha, but City already has its 2 positions filled with more preferred applicants. She cannot match with City. The algorithm attempts to match Latha to her third rank, General, which has 1 unfilled position, so Latha tentatively matches with General. Finally, the algorithm attempts to match Darius. Darius is ranked City first, and City is ranked Darius first. Darius receives a confirmed match because he's the applicant most preferred by City. There's no chance he will be displaced later in the process. However, since City has only 2 openings, an applicant must be removed from City to make room for Darius. That applicant is Sunny, because she is the least preferred applicant on City's rank order list. The algorithm will now attempt to match Sunny to her second rank, Mercy. Mercy hasn't ranked Sunny, so she does not match to any program. Process is now complete and the match is final. All applicants except Sunny have matched to their most preferred choices possible. Although all of Sunny's choices have been attempted, she didn't match at City because Darius and Arthur were ranked higher by City, and she couldn't match at Mercy because Mercy didn't rank her at all. City in general filled all of their positions, but Mercy is left with both positions unfilled. Mercy didn't use the match to its advantage because it submitted a short rank order list. Joseph, Latha, and Darius used the match to their advantage by ranking all acceptable programs in which they interviewed in a preferred order to maximize their chances of matching. Arthur took a real risk by ranking only City. Data showed that applicants with short lists have a higher likelihood of being unmatched. Remember, a match commitment is binding, which means an applicant is obligated to accept the position and begin training if a match occurs. To learn more about the matching algorithm, visit the NRMP website.